All right. Hello, everyone. My name is Ahilan Sivaganesan. I go by Siva. It's a real pleasure to be with you all today for this interesting case discussion. I'm going to go ahead and share my slides and we'll get started. So I'm going to be talking about navigated endoscopic and tubular decompressions and whether they may represent an alternative to fusion in select cases. But just to introduce myself briefly, I'm a neurosurgery faculty at Thomas Jefferson. I've been in practice for a little over a year and a half now. I did my neurosurgical training at Vanderbilt. Clint Devon, who passed away a few years ago, tragically, was my main mentor there. Also, Rich Berkman, who is a neurosurgery professor at Vanderbilt, also a major influence for me. I then did the HSS Orthospine Fellowship and had the great pleasure of training under Todd Albert, Hanjo Kim, Shiraz Qureshi, Frank Schwab. And then now, of course, I'm at Jefferson and really want to make a point of thanking Jim Harrop for giving me an opportunity to be a part of this today. It's his sort of reputation and experience and name that's sort of given us this opportunity. I also have to give a shout out to Alex Vaccaro. I have the unique pleasure of operating with him pretty much every Wednesday at one of our Jefferson hospitals and learned an incredible amount from him as well. And so I want to give him a shout out also. So, before I start, I want to talk a little bit about the why of what we're going to be discussing today. The what is navigated endoscopic and tubular decompressions. The how of that, I'll get into a little bit. And then Adam Leibold and Evan Fitchett, two rockstar residents with neurosurgery at Thomas Jefferson, they'll be getting into some of the nuts and bolts of the how as well with some of the case presentations. But I wanted to take a few minutes to talk about the why, because it may not be obvious at first glance. So this is sort of a cartoon schematic of a typical, OR schedule you might find at any hospital. And I picked this one because of what you see in these two red boxes, where you see the surgeon that has two decompressions on the board. Maybe one is a first start and another one is following right after that. Sometimes I feel like this is a representation of my OR schedule. Just last week on one of my OR days, I had a posterior cervical tubular laminectomy, followed by a navigated transforaminal endoscopic decompression. And this coming week on one of my OR days, I have a similar day. I have another tubular cervical posterior decompression, as well as a tubular cervical foraminotomy. And, as I was thinking about this, something didn't quite sit right with me. And I realized that instinct is this feeling like maybe I'm underutilizing my OR time. And I wasn't sure exactly where that feeling came from. And, very quickly, I was able to sort of pinpoint what the underlying sentiment was. Everybody knows RPM, revolutions per minute from a car standpoint. But I realized is that most surgeons, at least internally, have a clock, which is RVUs per minute or RVUs per hour, RVUs per OR day. And obviously, we're all trying to do right by our patients and do the smallest operation possible that can give our patients a good result. But there is also this external pressure, whether it's in the form of RVUs or collections or what have you, where we all want to be, quote unquote, productive. And I realized that some of these choices I was making in terms of the cases I was doing in my elective practice seemed to be sort of underperforming when it comes to a RVUs per minute sort of ethos. And there's an obvious reason why. We all know what these numbers mean, these codes. These are arthrodesis codes. They're very friendly for spine surgeons, and there's a reason why, we all try to do the right thing by patients, but if we feel like a spinal fusion is indicated, it's a good thing for us because it helps keeps the lights on and it's good for our productivity. So as I felt this sort of undercurrent of this external pressure just from the financial incentives around all of us in healthcare, I wanted to take a step back and say, let's look at the healthcare landscape specifically around spine and see if this external pressure is real and what we can do about it. And that's going to be the lead into the type of cases we're going to present today. So I wanted to do essentially a bit of a SWOT analysis on spine surgery and the healthcare landscape. And let's start with the weaknesses of our field. And I think the biggest one is embodied very sort of clearly in the Steve Kerr story, which many people may be familiar with. You know, he had a microdiscectomy, had some complications, CSF leak issues, eventually resolved. But this is a quote that got sent around a lot through the Washington Post, where he said, "I can tell you, if you're listening out there, stay away from back surgery. I can say that from the bottom of my heart, rehab, rehab, rehab. Don't let anyone get in there." And this is the zeitgeist. This is sort of the external environment that we are operating within. And on top of that, there are some threats to the status quo, probably good for patients in the long term, but definitely a changing of the guard when it comes to the regulatory landscape that we live in. This is a paper in the New England Journal. The senior author, or the only author of this paper, is one of the CMS administrators that runs CMMI, the Center for Medicare and Medicaid Innovation. Essentially, what he says in this recent New England Journal article is that there is going to be a push to make bundled payments mandatory and not just voluntary. And our orthopedic colleagues are somewhat familiar with this from the joint replacement domain. And I think it is pretty inevitable that within the next few years, we're going to start seeing a phase in of mandatory bundled payments. At Wharton, a pretty seminal white paper was also written talking about mandatory participation in bundled payments. And not only that, but incentivizing providers and health systems to join bundled payments through telehealth waivers, reducing the out-of-pocket costs for patients and so forth. So I'm seeing all this, and I'm thinking to myself, okay, if I'm planning a career for the next 25, 30 years, and these things are coming down the pipeline, what can I do as a young surgeon to prepare for this? This is a paper that I published 6-7 years ago through the Vanderbilt Prospective Spine Registry, where we looked at the variability in long-term patient-reported outcomes after lumbar fusion, whether it's ODI, SF12, EQ5D. Each point on the plots on the bottom is an individual patient, and the baseline is on the x-axis and the 12-month scores on the y-axis. And you can see incredible variation across surgeons, across hospital sites at Vanderbilt in the patient-reported outcomes for lumbar fusion. We all know this in our own practices and just through experience. Another paper I'd like to mention that we published through the QOD, now the ASR, was to say, all right, look, policymakers know that there's a lot of variation in spine surgery outcomes, and in particular in fusion outcomes. They are probably going to start trying to do some sort of ranking of providers and practices so they can route patients to the so-called best performing providers. And we thought to ourselves, let's get ahead of this. Let's have spine surgeons own this area and come up with a mechanism for risk-adjusted rankings of providers and practices with respect to patient-reported outcomes that are specific to our field. So this is an example of a plot from that paper where we show 12-month satisfaction rankings for surgeons and practices using QOD data. So this is something that's advancing in our field, and I think the more we take ownership of this, the better. But of course, when it comes to value-based care, which is the sort of mantra behind bundled payments or capitated payments or population health, whatever, what have you, the other side of the equation is, of course, cost. So here's an example of a paper where we looked at Vanderbilt spine surgeons when I was a resident at Vanderbilt, and we looked at their cost profile for single-level lumbar fusions. We looked at that before risk adjustment and after risk adjustment for comorbidities. And we saw a significant change in where surgeons stacked up before and after those adjustments. So this is useful information. Surgeons would like to have this information so they can decide how to stay lean and increase the margins for their hospital. What it then brings us to, though, is this sort of plot, which we are looking to publish now, but it's not yet published. This is based on Jefferson data now. This is looking specifically at one-level ACDFs. On the y-axis, we have average NDI improvement at 3 months. And on the x-axis, we have the true intraoperative cost for that procedure for that surgeon. Each bubble on this plot is an individual surgeon, and the diameter of that plot corresponds directly to that surgeon's case volume for one-level ACDFs. And again, to emphasize, the cost here is not charges, it's not reimbursement, it's not collections. it is using time-driven activity-based costing to understand the true intraoperative cost profile for these surgeons with respect to one-level ACDF. And why I think this sort of plot is important is that you can start to understand who the high-value surgeons are and who the lower-value surgeons are. You want to be in the top left quadrant here, where you're achieving, on average, very high patient-reported outcomes at a very low cost profile. Now, we've been doing this work for about a year now, but what had occurred to me is that this may not actually be the most important visualization as it matters for stakeholders in healthcare. If you replace one-level ACDF with instead a diagnosis like cervical radiculopathy, this is where things are going. Because right now, bundled payments are traditionally organized around a procedure, but very soon they're going to be organized around a diagnosis, what we call condition-based bundled payments. So if one surgeon is doing a posterior cervical foraminotomy for cervical radiculopathy for an appropriate indication, and another surgeon is typically doing an ACDF for that pathology, on that metric, surgeon X is going to look better, assuming they get similar patient-reported outcomes because their cost profile is going to be less. And it occurs to me that this sort of value-based comparisons of surgeons, of health system, is probably where things are going to go. And to that end, there's an analysis we did that we submitted to CSRS this year as an abstract, where we used time-driven activity-based costing to look at the true intraoperative cost for a one-level ACDF versus a posterior cervical foraminotomy for cervical radiculopathy. Now, we all know, obviously, because there's no implants in a cervical foraminotomy, that the cost profile should be less. And that, of course, bore out. The average cost of a one-level ACDF intraoperatively at our institution was about $7,500. And for a cervical foraminotomy was about $3,000. So if we're all going to be measured on how we're addressing certain diagnoses, and we're going to be rewarded or penalized by the type of procedure we choose or no procedure at all, this kind of analysis is going to be important. And we also have a review paper on the TD-ABC methodology that we used if anyone else is interested in replicating that. So what occurs to me as I think about all this is that, we talk about adoption curves when it comes to spine surgery, orthopedics, and neurosurgery, and we usually talk about it in the context of techniques or technologies, whether it's robotics, navigation, MIS, endoscopy, motion preservation, what have you, and whether you want to be an early adopter, part of the late majority or not. But my contention now is that for young surgeons, mid-career surgeons looking at the next couple decades of practice, is that we have to apply this sort of philosophy to the question of, are we ready for value-based care changes that are coming? And are we ready to be measured on the patient-reported outcomes that we are delivering per dollar spent when we're measured on a diagnosis and not just on how good we are at doing TLIFs or ACDFs or that sort of thing? And there's a chasm here. Nobody really wants to jump into this fray because of the fee-for-service model that we all are optimized around. Most of our practices are optimized around fee-for-service. We want to do right by patients, not do anything more than we have to, but we live in a fee-for-service mentality. And in my mind, what's going to be smart over the next few years is trying to break this mold and sort of try and get ahead of the curve for the kind of condition-based bundled payments and population health-based reimbursement models that are coming down the pipeline. So my philosophy in recent times as I've come into practice is basically this. Can I spare the patient in front of me in clinic a fusion, if at all possible? And can I accomplish the goals of surgery without leaving any metal behind, while accomplishing a durable, meaningful clinical result for that patient? I think a lot of us do this, but there are external pressures. And I think having a laser focus on this sort of ethos will be favorable in the coming years. And, just to be clear, I'm not anti-fusion. I don't want to make that come across in any way. I think spinal fusion is an incredible operation for the right indications. And just to sort of, prove that point, when I was a resident in 2016, I saw this New York Times article, Why Useless Surgery is Still Popular. And they used spinal fusion as the poster child and basically incorrectly cited the sport data to claim that spinal fusion was a useless surgery. So I actually got together with my mentors and we wrote an op-ed for the Boston Globe with their offshoot, healthcare offshoot Stat, entitled Often Maligned Spinal Fusion Surgery Can Make a Real Difference in Patients. So I really believe this, and I may be one of the few people that has actually put something out into the general lay public op-ed literature to that effect. But having said all that, here's our real competition. Okay, this is Virtos. They're the company behind the mild procedure. I went to their website, and this is on their front page. It's a schematic that shows the different kind of options that patients have for lumbar stenosis. They have epidural steroid injections, the mild procedure, spacer implants that are put in by a pain management physician, and then open surgery on the right. And on the column all the way on the left, you see complication risk, implants and stitches, recovery and post-procedure restrictions, and then typical duration of results. And it's striking there. For open surgery, they say that the complication risk is high. They say, of course, you need implants and stitches. The recovery and post-procedure restrictions are severe. And sure, the duration of results is lasting. And for this open surgery, it's not just fusions. They're talking about laminotomies and laminectomies here. So this is the kind of competition we see in the marketplace. And I think this is actually more of our competition than competition within amongst ourselves as orthopedic surgeons and neurosurgeons in a given regional marketplace. This is one of their sort of seminal papers for the mild procedure. They describe it as a removal of small amounts of lamina, and they describe their technique as debulking of the ligamentum flavum. And they say when there's no longer material to debulk and the instrument falls into the channel created by the decompression, the procedure is complete. So you can take that for what you will. But in their conclusion, they say, the mild procedure is recommended as the first intervention after failure of conservative measures. So, and of course, if you look at the list of disclosures and conflicts as part of the publication, you see Virtos listed all over the place for the author list. So this, I think, is really what's coming down the pipeline. And while I think people have different opinions about the mild procedure, I do think that it does represent an example of disruptive innovation if you really understand the true definition of disruptive innovation by Clayton Christensen, where he says that it's an innovation that is low performing, but that is tailored to a segment of the consumer population that is low demand. And that is essentially what the mild is. Maybe it works, maybe it doesn't, maybe it works a little bit, but for patients that aren't really demanding a lot and don't really want to go for traditional surgery, they're identifying those patients and they're scooping them up. And so to that end, what I have wanted to do as I've started my practice is to say, okay, what are the opportunities for us as spine surgeons to not ignore the zeitgeist and to actually provide new opportunities for minimally invasive procedures that get rid of some of that stigma around a lot of what we do and provide good results for patients. One example of that, as a quick shout out, is what I think 3Spine is doing with their lumbar total joint replacement. I'm one of the PIs for this study. We haven't started enrolling patients into the experimental arm yet, but some of my colleagues have. And so I think that could represent an interesting innovation, and we'll see. But the two areas where I have found opportunities to hopefully make a small mark towards what I've been discussing so far is one, posterior cervical decompression, and secondly, bony foraminal stenosis in the lumbar spine. So when it comes to posterior cervical operations, it always seemed to me this one area where MIS had not really penetrated. We have a huge amount of paraspinal musculature in the posterior cervical spine, and yet a lot of MIS surgeons, if they feel like a patient has cervical myelopathy from multi-level cervical stenosis, they'll do a laminoplasty, which is obviously, less invasive, less disruptive than a posterior cervical decompression and fusion, but still involves a lot of muscle disruption, a midline incision. And so it is in an effort to try and bring some more minimally invasive attention to that I started doing tubular cervical over-the-top decompressions with navigation, which we'll talk about here in a minute. And then the other area through endoscopy is the idea of attacking foraminal stenosis. Now, there's a lot of debates about whether there's an incremental advantage to interlaminar endoscopic techniques versus tubular or open. But when it comes to transforaminal, it's obviously a fundamentally different approach where you're using a natural aperture, a natural opening in the body to access the neural elements. And I find that if you can potentially avoid a fusion by addressing bony top-down stenosis from DDD and exiting nerve root pathology with a transforaminal endoscopic decompression and save a patient a fusion, that may be an opportunity to provide good value to patients, to all stakeholders, and advance the field a little bit. And I want to thank Dr. Jack Jallow. He's one of my senior partners at Jefferson who got the endoscopic program started at Jefferson and enabled me to start doing some work in this area. So I'll speak briefly about the posterior cervical MIS decompression first. I have to give homage to Dr. Hartle, who's published one of the few papers on this topic, giving his 10-step approach to minimally invasive cervical decompression through a unilateral tubular laminotomy. And I also want to give credit to Martin Pham at UCSD, who's published some very nice operative videos of this technique, and they were the inspiration for me starting to do this kind of procedure. So here are a couple examples, some pictures from the operating room showing our setup. So what we do is we have the patient on a Jackson table with a C-flex, and then we attach the navigated stealth reference array to the C-flex itself. Here's another view of that. You can see the dog bone adapter that allows you to attach the C-flex to the Jackson apparatus and then to attach the reference array to the C-flex. And then here's post draping where you can see the post for the reference array, the reference star. Here's some screenshots of a couple of our cases. So I've started using the exoscope for my tubular decompressions, which has been really great, both for ergonomics, visualization, and also for fostering more of a team mentality in the operating room where everybody can see exactly what we're doing at every step. So you can see on this left picture here, the view through the exoscope. The surgeon, the assistant, they're all standing upright. They're not sort of leaning their body to work through loops or through a microscope. And if you see in the distance there, you can see the navigation display as well, where I'm using a pointer to see exactly where I am in the cervical spine. And then over here on the right, you can see a snapshot from the initial dilators. This navigated dilator getting down to the spine so that we can dock exactly where we want to dock. So here's a video that I'll play, which actually shows, hopefully this comes through, part of the decompression here. I'm using a navigated burr here. So you can see the view through the exoscopic screen in the center. And then if you can see on the right, you can see the live navigated burr tracking as well. So you don't have to switch between a burr and a chicken foot or a navigation pointer back and forth to know exactly where you are relative to midline, lateral, and that sort of thing. This is a snapshot showing the over-the-top decompression verification. On the left, you can see the view through the exoscope, and then on the right, you can see the pointer going over the top and showing that I've gotten to the contralateral side. So this is something where I think is a unique advantage of navigation in this sort of scenario. And here's a quick video showing sort of the end of the case, an over-the-top one-level cervical decompression through a tube. So why I think this may be sort of underutilized procedure is that, for rightfully so, we do posterior cervical decompressions and fusions often to prevent post-lectinectomy kyphosis. And some surgeons like to do laminoplasty when possible to preserve motion and perhaps reduce the burden that comes with a fusion operation. I am curious to see whether over time we can start attacking 2-level or 3-level cervical stenosis through a tubular over-the-top decompression, and perhaps provide a third option for patients with multi-level disease that has a much significantly lower cost profile and less morbidity to patients. Now, obviously, it could be a time-consuming procedure, and so we'll all have to get faster and faster at these 1-level decompressions before we can move on to 2-level or 3-level. But that's sort of what I'm seeing sort of potentially in the future as one potential use case of this kind of technique. So before I hand it over to the residents, the second type of case that we're going to be presenting today is about transforaminal navigated endoscopy and whether it can be used as an alternative to fusion in certain cases. The reason I got interested in endoscopy, honestly, was when I was in fellowship at HSS. Chevy Iyer, who's a surgeon there, I watched him do his first transforaminal endoscopic procedure, and it was a foraminal disc herniation. And I saw him do it. It was first surgery. It went amazing. And I thought to myself, wow, this is a procedure which is, a little bit annoying if you do it open. Sure, you can do it through a tube as well, but it takes a lot of effort and a lot of planning. And with endoscopy going transforaminal, you took something that it's quite challenging and made it very simple. And then I would go to these MIS courses, and I felt like the traditional MIS surgeons were sort of discrediting endoscopy in the same way that open surgeons used to discredit MIS. They'd say, well, what's the difference between a 18 millimeter incision and a 7 millimeter incision? My patients go home the same day, your patients go home the same day. That's kind of what the open surgeons used to say about tubular surgeons. And so I got really interested in endoscopy, and I started doing, transforaminal endoscopic procedures myself in practice. And then I realized, wait a minute, why don't we incorporate navigation into this to just make it more of a reproducible deliverable product each time? And so this is an example of the workflow that we've come up with using stealth navigation in the O-arm. So this is an example here you see on the left. The teal light blue line is actually the pre-puncture plan that we came up with using a navigated Jamshidi on the stealth platform. And then we enter with the navigated Jamshidi to dock on the foramen in exactly the place that we planned at. And not only are we doing foraminal targeting with this approach, we're also putting a SureTrack navigation adapter on the foraminal reamers, and we're putting a navigation array on the endoscope itself. So the reason that I show the picture on the right is, one, you can see I'm not wearing lead. There's no C-arm in the way. There's a lot of free space between me and the patient. And what I've circled in the bottom right there is you may be able to zoom in and see that's a SureTrack array on the endoscope, so that at any point, if I want to double check where I am in the foramen, for example, I can just make sure that my nav array is facing the eagle eyes, and I can see exactly where I am in the foramen. This is some other examples of what exactly our setup looks like. So on the left, you see a SureTrack array attached to the foraminal reamer. So instead of having to take serial AP X-rays to see when you're getting close to the medial wall of the pedicle on the AP fluoro, you can just use navigation and not have to take serial X-rays. And then again, on the right, you can see the SureTrack attached to the endoscope itself. And here we're placing a pin in the pelvis. This, I have to say, is one of the drawbacks of this procedure, is that we're trying to be MIS, and then we're making a whole separate incision to put in the navigation post. But I do think that skin-based navigation solutions, such as spine mask or others, will enter the fray. And I think there will be a role for navigation in transforaminal endoscopy. Perhaps not for every case, but for a growing set of cases for those surgeons that are interested. And so, why navigate minimally invasive or endoscopic decompressions? Just to be selfish, I think one is wellness. I'm thinking about a 25, 30-year career and the X-ray burden that I might incur, and using navigation, I think, can avoid some of that. And I give full credit to Shiraz Qureshi at HSS for sort of showing this to our fellowship class and sort of showing that example. I also think it can improve efficacy, specifically at L5-S1. The case that I showed in the previous slide was an L5-S1 case, and it can be hard to thread the needle, avoid the crest, and get to the L5-S1 foramen, but you can do that more reliably with navigation. And I do think, as well, as has been discussed in this forum through SSF before, there's going to be a role for robotics in transforaminal endoscopy, whether it's for decompression or for fusion. And I think that surgeons that get adept at using navigation with endoscopy will be that much more well positioned to take advantage of robotics when it also comes into the fray as well. So, in general, I would say that the ultimate sort of trade-off that we make when we do minimally invasive surgery, endoscopic surgery, is that we sacrifice visualization to reduce invasiveness. And that's sort of a core sort of trend that we see. But I do think that by using navigation for over-the-top decompressions through tubular work or with transforaminal endoscopy, we can actually increase our visualization while maintaining the minimally invasive nature of these procedures. So I'll close by saying, sometimes I feel like a bit of a loner when I'm doing, posterior cervical foraminotomies, navigated endoscopic transforaminal decompressions, and wondering to myself, gosh, most people might have done a fusion in this case. Maybe they would do a posterior cervical laminectomy and fusion instead of a 2-level tubular cervical decompression. But I think the ground is shifting under our feet, and the extent to which we can measure ourselves on the patient-reported outcomes that we're achieving per dollar spent internally and externally for patients and employers and payers, I think we'll be well positioned for the coming changes that are coming in healthcare policy. And so with that, I'd like to just briefly introduce two rockstar residents at Thomas Jefferson Neurosurgery, Adam Leibold and Evan Fitchett. They're both upcoming PGY5 residents, both going into spine, and you'll be seeing a lot more of them in the coming years. So I'll close with that, and if anyone has any questions or comments, would love to chat about it, and then we'll turn it over to the residents.
And you are muted, Dr. Leibold.
All right, so if there's no questions or discussion, I think I can just jump into some of the cases.
There's one question, sorry, Adam, one question that we got,
Oh, you're fine.
Which is that regarding cervical myelopathy, there is indeed significant literature that suggests micro movements play a role in the pathology, even when clear instability is not observed in imaging studies. Some studies even propose fusion surgery for all myelopathy patients. How do you address that? That's a great question. I think there's pretty good evidence out there that for the appropriately selected patient without focal kyphosis and a reasonable alignment, that laminoplasty can be a very good alternative to posterior cervical decompression and fusion. There's also good data out there that shows that in the appropriately selected patient, cervical disc replacement is a good option as opposed to ACDF for certain myelopathy patients. So I take the point about micromotion being a contributor to myelopathy, but I think we should do some prospective studies. We should look at, patients with, say, 2-level cervical stenosis causing myelopathy, and how do the modified, the MJOA scores compare when you do a over-the-top minimally invasive navigated decompression versus a posterior cervical laminectomy and fusion? And what are the long-term clinical outcomes as well as short-term outcomes? The other question we got was, which company provides navigated endoscopes? It's a great question. So to my knowledge, the main sort of navigated endoscopy platform that exists is called Intrax by Joymax. I don't think it has a huge amount of usage, probably because it's only usable for endoscopy as opposed to every other navigation solution, which you can use for all sorts of spine applications. So what we have been doing here in my practice is merging endoscopy with stealth navigation in our particular situation, and using the fact that the SureTrack adapters can be fit on to many different shapes and sizes and turn them into navigated instruments. And I'm guessing that something similar can be done for other major navigation platforms, whether it be BrainLab or Stryker Navigation, but we've been using Stealth in our shop, and it's worked well. I don't think I've done a non-navigated transforaminal endoscopic procedure in about 3 or 4 months now. All right, I think we can switch over to the case presentations now.
Okay, let me just share real quick. All right. My name's Adam Leibold. I'm one of the residents at Thomas Jefferson. I'll be going over kind of the lumbar endoscopy cases that Dr. Siva introduced earlier. So our first patient, 45-year-old female, she had 2 months ago, she had a acute onset right lower extremity pain with with right leg weakness. She developed a foot drop. She saw her PCP. They went and sent her for an MRI. MRI is shown here. You can see at L5, S1, you can see it scrolling out to the right foramen right there. And you can see it on the axials on the right. More so, the T2 on the top right is not as good as the T1, which you can also show it on the bottom right. But you can see that there is an acute lateral disc herniation. There is a paracentral component going out the foramen and compressing the nerve into the foramen, and an extraforaminal component. So this patient has minimal back pain. She comes to us in the ED because she got an injection, which helped her for she said a week. and then her pain came back and she's having an acute worsening and she can't control it. So we get consulted. So the question then for this patient is kind of what are the options that we have? Has she even bought herself a surgery? She's only had 2 months of symptoms. She's had the foot drop for 2 months, unfortunately, before she got to us, or we weren't able to operate on it acutely. So has that ship sort of sailed? Does she? Is there even a reason to operate on it, or should we be sending her to physical therapy? And as we all know, how these disc herniations usually go away on their own. If she has, then what are we doing here? Is there a role for a microdiscectomy and a foraminotomy? Are we able to get that foraminal and that extra foraminal component? Or do you need to do a fusion? Do you have to do a facetectomy in order to get to that disc and that compression? And then end up fusing this 40-something-year-old. Or is there an endoscopic option, which I think we know where this is going for us. So what we did was an L5-S1 endoscopic discectomy. A lot of times these L5-S1 endoscopic discectomies can be difficult due to the iliac crest. You can see the X-ray on the bottom left. It shows that she actually has a really favorable crest. The crest only goes up to L5. So the angle is not as acute to get to that L5-S1 level. And talking about the navigated endoscopes, you can see here kind of our solution using the SureTrack device from Medtronic. We use the O-arm. We place the pin, like you said, in the right iliac crest. And then we are able to attach the SureTrack to the reamers, which you can see on the right side to show the exact area in the foramen that we're reaming. And then again, to the endoscope or to the grafter in order to show exactly where we're going, which helps us in sort of these difficult angles getting to L5-S1 discectomy. So our patient, he's doing well. She's about 6 months out. She had 90+% improvement in her right leg pain, which has lasted. She still continues to have that. She has mild back pain, which she's had chronically, which she continues her outpatient PT. But for now, she has a lasting solution to her back pain without having to have undergone a larger surgery or fusion. So, if anyone has any comments or questions, or if they would have done something different, would here. No. Okay. So the second case, we can go over somewhat similar, that has a little bit different. This is a 60-year-old female. She has chronic back pain. She's a pack per day smoker, and she has some cardiac issues. So she's been followed for a while for this back pain and for this leg pain. She's had an acute worsening in this leg pain over the last 3 months. She's had what she claims is over 50 injections. So over the course of many years, she keeps getting injections for these leg pains, and it does help her every time. She's avoided having any surgery, partially because she does refuse to quit smoking. She's a pack per day smoker. And then she presents to us because this back pain and this leg pain is getting worse. So you can see, scrolling out the foramen on the left, you can see that there's a spondylolisthesis at L4-5. And there is a disc herniation with pretty severe foraminal stenosis compressing that L4 nerve. So she has left greater than right foraminal stenosis. She does have a component of back pain with a spondy. I'm not showing it here, but she did get a flexion extension films, which show that it is an immobile spondy. So she does not move on flexion extension. So then again, for this patient, kind of what are the options? Again, we can talk about a fusion. I think a spondylolisthesis with stenosis is pretty slam dunk for a fusion, whether that's a TLIF, an ALIF in this case, or something like that. Do you, because it's an immobile spondy, try to just do a laminectomy and a discectomy, and again try to do a foraminotomy, or can we, in this patient who is again an active smoker and may have some concerns with her ability to fuse, can we give her a more minimally invasive endoscopic option here? So what we did for her is we did a left end L4-5 endoscopic foraminotomy. Again, we can navigate these, and for her, she has actually a little bit of a different story. So she was given lasting lower extremity pain relief for almost a year. So she spent almost a year having relief of this left lower extremity pain. She was able to get back to her daily activities. She was very happy, and then slowly over the couple months after that, her back pain began to worsen again. You can see in the X-ray on the right, her spondylolisthesis is a little bit worse. And so this is one of these patients that, we gave her a minimally invasive option. She received relief from this option for a much longer period of time. She really only got about a week or two of relief usually when she would get injections, and this gave her almost a year of relief. But I think now it's to the point where she has bought herself a fusion. So she actually is going to be going for, she's actually scheduled to undergo her a TLIF coming up soon. So her story's not over. But she kind of represents what we see in our data. So we looked at these patients that have lateral foraminal stenosis and these lateral disc herniations. And we looked in our lumbar fusion database, then we looked through our endoscopic cohort, and we wanted to see kind of how these patients are doing and wanted to compare them. So I think we found similar outcomes for patient reported outcomes in ODI and VAS. Obviously, the length of stay for the endoscopic patients is going to be less. But I think if I could draw your attention to the bottom right for the reoperation. So she is someone that represents the cohort for that gets reoperated on. But so we can see that the reoperation reasons for someone that gets a fusion on the right or someone that gets an endoscopic decompression on the left are very different. So on the right, they have the complications that we all know with getting fusions. And this is on the right for our fusions is over 3-year follow-up. They get adjacent segment disease, scoot arthrosis, and things like that, requiring, like we all know, the sort of snowball effect of fusions or extension of the fusion and can lead to further complications. The endoscopic cohort, it's not abnormal that we see these patients requiring revision decompressions. And she's one of those that can go back for another decompression, but some of them do progress to fusion. We don't consider that to be necessarily a failure. We were able to kind of delay her fusion a year and give her a little bit more time before being exposed to the complications on the right. But this is something that we talk about extensively with our patients to make sure that it's fully understood. So.
That's great, Adam. Maybe one comment I'll make to address one of the questions as well. There was a question about, how much facet do we end up taking? It's a great question. So for that first case, because it was a paracentral and foraminal, extraforaminal disc, the only real foraminal work we did, bony work, was with the reamer, and didn't do any work with the burr to sort of shave down more of the SAP. But with the second case, we did some more resection of the SAP. Now, what I will say, and what I think a lot of endoscopic surgeons will say, is that, when you do a transforaminal approach, whether you're doing foraminal reaming or using the burr, you're really working on the non-articulating surface of the SAP. So, and everything's magnified. So I think you were actually taking less sort of functional facet than you might realize. But I do think that's an open question for research to actually look at, are we taking more than we think we are, things of that nature. And I think that that's also a place where navigation can help to make sure that you're really docking on the caudal aspect of the foramen. Because my sort of question that I'm sort of posing to the spine world is that, traditionally, when you look at the list of contraindications for transforaminal endoscopy, one of them is bony foraminal stenosis, rightfully so, because you're worried about, injuring the DRG and being too close to the exiting nerve root. But if we could solve that problem, and whether it's through a trans SAP docking, perhaps through navigation or not, be able to create extra space in the foramen for patients with exiting root radiculopathy, perhaps there's a subset of patients that could get better enough without a fusion and not necessarily have to get jumped to a fusion at the get-go. So I think it's an open question that we can look at more in the coming months and years. Adam, do you want to? Yeah, there you go. Perfect.
Yep.
Hello, my name's Evan. I'm one of the rising PGY5s at Jefferson as well. And I'm going to be going over the cervical cases. There's two cases. They're very similar in a lot of respects. The first one is a woman who was 83 years old. She initially presented to us over a year and a half ago, in a kind of like a central cord type injury. had cervical stenosis and had a fall, had bilateral hand weakness, and some paresthesias and dysesthesias. She was found to have stenosis, and she actually initially underwent 3 to 7 posterior cervical decompression infusion. She did very well post-operatively. She went to rehab. She regained significant amounts of strength. She was seen in follow-up over the following year with improved motor control and only had some minor residual fine motor deficits in her hands. And then a year and a half post-operatively, she developed signs of cervical myelopathy, gait instability, imbalance, proximal lower extremity weakness. MRI findings showed stenosis of the adjacent segment at C2-3. And incidentally, it was also found to have some C7 screw lucency. Her primary complaint was myelopathy. There was no significant component of neck pain. So I think the options here that are reasonable to discuss are extension of her fusion and decompression up to C2, considering even extending the fusion up and down, given the lucency at C7, which is quite a large surgery for her. And then another option would be an MIS decompression, obviously given the topic of today. We ultimately opted to undergo tubular cervical decompression, unilateral laminotomy with over-the-top decompression, as Dr. Siva had described earlier. We used navigation and the operative setup that he demonstrated earlier in the slide set. Just some quick operative notes. The patient was able to be discharged post-op day 1 with a stable exam, and then follow up with 1 week. She already had improved ambulation. This patient's only several months out, but she continues to do very well. She has a very small incision. Her gait dysfunction is resolving and significantly improved. The second patient is a 68-year-old female with a history of a prior ACDF for cervical stenosis and cervical myelopathy. She presented with recurrent symptoms of cervical myelopathy, gait instability, imbalance, and MRI findings showed, again, she had adjacent segment stenosis that was most severe at C3-4. She was solidly fused in her prior construct. Of note in her history, she was a smoker, but it did not seem to inhibit her prior fusion surgery. So the reasonable options here, I think, a lot of people would go the extension of her anterior root, try an approach from the front, and do an ACDF at 3-4, which I think is a reasonable option and probably one that would be most commonly selected. There is always the option of a posterior approach if you're concerned about her alignment or about her fusion prospects. A larger construct above and below could be considered. That's obviously a much more morbid surgery, much more postoperative pain, and more blood loss, without necessarily guarantee that of a fusion result. But in her case, her alignment is reasonable. I don't think there is too much concern that she needs some sort of a posterior back up to her previous anterior surgery. And again, history of smoking. In her, we actually opted again to do tubular hemilaminotomy with over-the-top decompression. Similar setup, we used a microscope in this particular case versus the last case was an exoscope. And she was actually able to be discharged post-op day 1 as well with a stable exam. She also had improvement in some radicular symptoms that she presented with, and then post-op several months out, she already has significantly improved gait and balance function. Just some quick data there. The data that exists for the tubular and MIS cervical surgeries is still, I think, in early development. In my mind, there's really 2 kind of categories that are important and emerging. The first one is clinical outcomes. The big question, needs to be answered, the proof of concept. Do these surgeries provide clinical benefit for patients? There is limited data. There's mostly case reports, case series from institutions that are adopting this technique, showing that in small series of 5, 10, 15 patients that they have good results. There's one retrospective comparative analysis, or one significant one at least, with 74 patients that showed that there were similar clinical outcomes between patients who received ACDF versus tubular decompression alone. Followed up to 31 months, they all had very similar scores, NDI, NECVA, SMCS scores. There were slight differences in the populations, MIS patients being older and undergoing more levels than ACDF. And I think that is a product of patient selection, obviously, and a bias there. Patients who are older, significant comorbidities, maybe either less willing or not as good of candidate for fusion surgery. And so the surgeons at this particular institution opted for an MIS approach, which just highlights the need, like Dr. Siva said, for prospective kind of research in this topic. And then the second kind of category of research in my mind is looking at the surgical outcomes. There is still very little data regarding the surgical outcomes, particularly the complications that people worry about with cervical decompression alone. As was mentioned in the chat, in patients with myelopathy, there's concern of micromotion, and there's some evidence or some feeling that all of these patients may require instrumentation. So what we have to go on really is the original literature for open cervical decompression alone without fusion, which showed that there were rates of posterior kyphosis up to 46% and late deterioration of myelopathies up to 37%. And honestly, we don't see these patients that often. Open laminectomy, cervical laminectomy is not really a surgery we do at our institution. And really the only time we see them is when they've failed and they present to us with worsening deformity and worsening myelopathy, and then ultimately end up requiring a fusion. So there really is a need, I think, for long-term surgical outcomes data, looking at the complications and the effects of delayed instability and kyphosis and eventual need for possible fusion in patients who've received MIS tubular.
That's great, Evan. I can touch on some of the questions and comments in the chat. Thanks for everyone's participation. So the last one is the question of, are we getting post-op scans for these MIS cervical decompressions to see how much decompression was done? We have not been doing that routinely, but we are planning on submitting a grant proposal to the CSRS, specifically doing regular, not just MJOA clinical tracking of myelopathy improvement, but also radiographic improvement, and then comparing that against a control arm of posterior cervical fusion or laminoplasty. So I think that's a great question. Let me see what some of the other. There was also a comment about the first cervical case and how it was iatrogenic and potentially preventable. I think that's definitely the case. Adjacent level disease after posterior cervical fusion. Were there technical issues with sort of disruption of ligament or soft tissue, cranially, that may have increased the risk of adjacent level disease, or would a more targeted surgery have maybe reduced the risk of that? I think absolutely. And I think that also, begs the question, if you do a tubular over the top decompression above a fusion, whether it's anterior or posterior in the cervical spine, are you reducing the risk of post decompression kyphosis because you're sparing the midline structures, both bony and soft tissue and ligaments, or not? I think that's also an open question that deserves some study. Let's see some of the other questions. One comment from Dr. Gerdaki said that, I think bony foraminal stenosis is one of the indications for transforaminal decompression. I think that's very encouraging. There are a lot of sort of resources and surgeons that will sort of hesitate on that front, but I think Dr. Gerdaki saying that it is an indication, I think is very encouraging. And I think it could represent, those subset of cases where we're fusing patients for bony foraminal stenosis and exiting root radiculopathy, some subset of those patients may be a candidate for these transforaminal endoscopic decompressions if they have the correct counseling. So I think that's definitely encouraging. The one person asked, what's the OR time for navigated lumbar discectomy? So if I take maybe, this is just kind of speaking sort of anecdotally over the last, say, 5 cases where we've done navigated 1-level transforaminal endoscopic decompression, probably for skin to skin, it's probably about, 45 minutes or so. Maybe a little bit longer depending on the nature of the pathology, whether it's a soft disc or not. But that's probably a reasonable estimate. There's a question about, do you perform tubular decompression for patients with acute traumatic anterior cord injuries? I have not done that myself. I'm not sure if anyone else has. Yeah, there's one question about CPT codes for the endoscopic approach. Yes, there is a endoscopic code specific to transforaminal decompression. But for the interlaminar approach, my understanding is that because it's you use a similar code to what is done for tubular open interlaminar decompression. All right. If there are any other questions or comments, thank you very much for letting us speak on this topic today. Really appreciate the opportunity and looking forward to seeing many of you in person at the coming events.
Steve, I want to thank you and your whole group. I especially liked your introduction. And I think there needs to be a whole paradigm shift. As you said, physicians should be reimbursed for treating a condition, not how much work they do, because there's all different ways of treating them. And I think you nicely pointed out that once you start paying surgeons the same price for treating a radiculopathy or some other similar condition, they will do the simplest and what's best for the patient, and we'll have the long-term data to show that it's a long-lasting procedure. So I think philosophically you're right on. It'll be a while before we get there because we're so ingrained for this fee for service, but I really think that's where we need to go. But I thank you for your insight and for your forward thinking, and I thank all your